Now, all women should be offered the chance to store their eggs or freeze their ovarian tissue to avoid fertility problems if they want to conceive later on in life. That's according to a report out today by a group of international fertility experts. Currently, those options are only open to women who are undergoing certain cancer treatments. Well, as with all treatments, there is a cost, and this morning we're looking at how the NHS spends its money. We asked people in Clacton what they thought.
I would say there's probably more pressing things, but then if we don't look to do that, then there's a possibility that sort of there won't be any more babies.
I'm 25 and I'm able to be really active with him, still have a really good job and look after my son and have more children and do the same with them, and I can do it all, so I don't need to wait.
So if another woman of 25 years old said, look, I want to freeze my eggs because I'm not ready for kids, I want to carry on having fun or going on holiday or whatever,
yeah.
How would you feel about your money being used to freeze her eggs?
I think everyone should have the right to do that, but if she was going to do that, maybe it should be her money.
I wouldn't say it's a priority, but I think when you're looking at cancer and leukemia and all of those sort of things, they normally come top of the list, don't they? But maybe to somebody that can't have children, fertility might be, their only lifeline for having a family, I suppose.
Well, joining me now to discuss these issues, author and mother of 2 children via IVF, Kiki Archer, and Beryl D'Souza, Honorary Secretary from the Medical Women's Federation, who is also a plastic surgeon. Thank you very much to both of you for joining us this morning. Okay. Before we get started, though, a reminder that you can join the debate too. Tweet us at Sky News, including the hashtag Sky Debate. Text us 84501 or email news@sky.com. You can also tweet me on @SkySamantha. Let us know what you think. If there's any points that you want to put to our guests here, we'll read some of your comments out as we go along. So Kiki Archer, let's start with you. You've had fertility treatment. You went privately for that. It is available to some on the NHS. Why did you decide to go privately, and how much did it cost you? And do you feel the NHS should have paid for it?
OK, it's actually my son's 7th birthday today.
Happy birthday.
Thank you. So actually, when we started treatment, it was 8 years ago, and I'm in a same-sex relationship. And IVF treatment wasn't easily available on the NHS 8 years ago. The provision is slightly better now, but that's the main reason that we chose to go privately for our treatment.
And how much did it cost you?
Cycles of IUI, which is intrauterine insemination, which is actually cheaper and simpler than IVF, costs privately, I think, around £2,000–3,000.
I mean, I don't know how many cycles you had to have to conceive, but do you feel that you say it was not really available to you on the NHS?
No.
Do you think it should have been?
Well, it is available now because the 2010 Equality Act has protected now LGBT people from any sort of discrimination when they are accessing fertility services, so it is available.
Beryl D'Souza, let's talk about your job, which is plastic surgery, because there is some plastic surgery which is available on the NHS. Tell us how that works. What kind of procedures are available and to whom?
Plastic surgery in the NHS, and if you're referring specifically to cosmetic surgical procedures in the NHS, are really for patients who have psychosocial problems and who have debilitating conditions that would warrant them having such surgery. For example, someone with breast asymmetry would be eligible for breast augmentation or breast reduction. Someone who has severe back pain would warrant having, with relation to huge breasts, would warrant a breast reduction. Someone with breathing problems could have a rhinoplasty.
It's all very subjective, though, isn't it? Somebody feels they've got a big nose or their breasts are too large. Somebody has to make a judgment call or whether or not they think it's worth spending the money on helping that person deal with what they perceive to be a problem when others might not.
So this is where we have to rely on a team. So we have to rely on a psychological assessment for the patient, and we have to rely on the clinical expertise. So it's very much an individual case and a clinical expertise with a team of experts involved here. But to say that it is not available, cosmetic surgical procedures are not available in the NHS is wrong, because it is offered for certain procedures. And plastic surgery per se in the NHS includes conditions like birth burns, hand trauma, elective hand conditions, cancer reconstruction. So equating plastic surgery with cosmetic surgery is wrong, really, because plastic surgery procedures encompass a whole range of surgical procedures and consultations. But there is obviously a real need for looking at the individual case and assessing it case by case, because there is need for in situations either related to congenital problems or related to trauma when people can't function, and we want people to be able to go into the community and work, and therefore if a procedure would help them do that, then it's very much needed.
And I think what we have to remember is that the rules and guidelines about what the NHS should and shouldn't pay for, they're not plucked out of thin air. They're based on the best evidence and the best research from a group of experts. And in terms of IVF, the group of experts feel that the NHS should offer 3 cycles of IVF. But unfortunately, what's happening at the moment, there's a real postcode lottery, because of the 221 care commissioning groups, only 38 of those offer those 3 cycles of IVF. So that's only 18%. So women are struggling to access those services. If you live in York, there's no IVF at all on the NHS. And infertility is actually a devastating medical condition, and it can cause huge emotional impacts if you can't access that treatment. So in terms of the funding, it's not so much there should be more IVF funding, but the NHS should be meeting what NICE believes is a reasonable
right to be able to have children.
Yeah.
But well, let's talk about more about the issue that we have introduced this debate with, and that is whether or not women of a certain age should be able to have the NHS fund them, store their eggs for fear that they haven't had children yet and they could struggle to conceive later on in life. Some people would say, actually, that's a lifestyle choice. If you want to get pregnant, and it's not about fertility problems per se, you're saying that obviously many people who have IVF problems have those issues. That's different. That's not a lifestyle choice. That's a medical condition. Should the NHS be funding women who say, actually, I haven't met the right man yet, I'm going to have my career, I'm going to wait to have children for a few years, I'm concerned that I might not be able to conceive later on in life, so I'm going to make the NHS pay for that?
I think, I'm not aware of figures, but I think the figures probably for that are absolutely tiny, because nobody steps into IVF lightly at all. And it's certainly not a lifestyle
That's a slightly
choice.
different issue. This is about freezing eggs, having the NHS pay to have your eggs taken and stored, so that then you can retrieve those later on when perhaps you may not have eggs that may be viable. Yeah,
I think it may be similar to the number of people who choose to go private for fertility issues compared to the people who have their fertility issues dealt with on the NHS. And at the moment, 6 out of 10 IVF cycles are done privately. So I don't know whether the same sort of figures would apply, that most people actually, if they were, the small number of women who are in that position would choose to go to a private specialist clinic.
What do you think, Beryl?
I think it's a difficult issue, and I think, again, it would, relying on the NICE guidelines for this is important, and also looking at the individual case. But with the NHS, there is always a problem. Which is more important, and where should the funding go to? And doctors are put into the situation where they are involved, and they have to make choices. They are advocates for the patients. And
that's the difference. That's what's been. There's been a shift in the last few years, hasn't there? That it's not just about here's the medicine, here's the potential treatment for whatever illness it is. It's now they have to judge people on their lifestyle and whether or not they should receive treatment on the basis of that. For example, your situation, you're in a same-sex partnership, so you can't conceive naturally with a male partner, obviously. So that's making a judgment, if you like, about your lifestyle, whether or not you should be eligible for treatment on the basis of that.
Yeah. I think sometimes what people forget with the NHS is that part of the Constitution highlights compassion. The NHS isn't just about people with life-threatening illnesses and diseases. The Constitution highlights compassion, and infertility and issues to do with like you said, it's not really a right to have a child. I don't have a right to have a child. It's my choice to have a child, and it's the best choice I've ever made. And I do think all women should have that choice. I think it's a very specific issue when you are just talking about the few women who potentially might want the NHS to store their eggs.
Beryl, what do you think how do we decide the final cut-off point for NICE to make their guidelines? As I said, it's a judgment call. Somebody has to make it, and there's always an argument whether it is a drug, whether it's, we've got, for example, the story we're doing today about these pills to help people who have alcohol-related problems to stop them drinking. Other people will say, come on, you know, just stop drinking. It's as easy as that.
Well, I think as NICE say, NICE offer guidelines, and guidelines are there to assist the team looking after patients, and so therefore the actual evolution of medical care using the patient with shared decision making and using integration of primary and secondary care means that the onus on the treatment for the patient, the best choice for the patient, is made with a lot of thought, with a lot of input from a group of people. And the patient support services that are coming to the fore now, and the patient support groups are also helpful in that aspect. What I'd like to highlight is the fact that it's a tough job for doctors, and doctors having to deal with this on a daily basis makes it very difficult. Our own organisation is having a conference later on this year in November, and it's to do with doctors' health and patients' health. And really speaking, we know from the evidence that's out there that doctors do not tend to suffer in the main from disease-related problems such as heart disease or smoking-related diseases, but what they do suffer from is stress-related diseases because they're having to deal with all of this on a daily basis. So this is something that needs to be actually thought about as well. So we're there for the patients, but what's out there? What's stopping us from being as helpful as we would like to the patient? It's the funding. It's the actual guidelines that are out there. That's the targets that need to be achieved. Is there any wonder what's come out recently that the GPs are wanting to retire early? It's a tough job. And so we empathise and we sympathise with our patients, but we're having a hard time too.
Beryl D'Souza, you made that point very strongly there. Thank you very much, Kiki Archer. Thanks very much for joining in the debate today.